on Plugged In, the United States taking the lead on a major health crisis in Africa. A delegation of experts led by the U.S. Health Secretary meeting with African leaders in a global effort to contain the world's second worst outbreak of the deadly Ebola virus. Just how bad is it? And what did the U.S. delegation accomplish? The answers on this special edition of Plugged In, Treating Ebola in Africa. Welcome to Plugged In. I'm Greta Van Susteren. An American health delegation led by the U.S. Secretary for Health and Human Services last month traveled to 3 African countries to assess the severity of the latest outbreak of the deadly Ebola virus. The outbreak, which started in the Democratic Republic of Congo, is now the second worst in history. Plugged In traveled with the Cabinet Secretary to visit an Ebola treatment facility at the epicenter of the outbreak. We also visited Rwanda and Uganda to survey the impact on neighboring countries. Researchers with whom we spoke say the development of 2 new drugs may hold the key to a cure and possibly an end to the latest outbreak. But as Plugged In producer Mil Arcega found out, despite recent breakthroughs, many serious challenges remain.
It's a journey few Westerners will make. Over rainforests and active volcanoes, past the winding, dusty roads leading to the remote village of Butembo. Here, elbow bumps replace handshakes. Shoes and hands are disinfected. Anyone who enters, checked for fever. This is U.S. Health and Human Services Secretary Alex Azar's first visit to the Ebola Treatment Center in Butembo, the front line in the battle to stop the deadly virus.
It's an incredibly tragic situation, especially to see the children. So many children. I think that probably was one of the things that struck me the most, were how many kids are here. But I also came away with more hope than I thought I would.
The outbreak began last year. It's now the second worst ever. More than 3,000 people infected, more than 2,000 dead. But there is hope for a cure. The development of 2 new drugs synthesized from the blood of an Ebola-resistant patient.
You know, it's a game changer. It's a game changer.
Dr. Anthony Fauci is part of the team that helped develop the new drugs. Another is Dr. J.J. Muyembe, who told Plugged In Ebola is no longer a death sentence.
And I can confirm that Ebola is now a disease that we can treat. It is not linked to the death. So this message is very important for the population. So the population will trust and bring the patient to the treatment center.
But cultural mistrust is common here. Some believe Ebola is not a virus, but a man-made poison.
The misguided perception of Ebola treatment centers in the past has been that sick people would walk into these centers and they would ultimately leave either in a body bag or in a coffin. But there's a lot of people in this community working hard to change that perception.
Among them, Mulyanza Huguet. The young woman made a full recovery after receiving the experimental drug monoclonal antibody 114. Today, she goes from village to village, urging families to seek early treatment. Another serious challenge is security. More than 100 warring factions vie for dominance along the porous eastern borders of the Congo. In this part of the world, protecting health workers is a full-time job.
Thousands of security incidents, and anytime you have disruption in your intervention, of course the virus will replicate and you have to catch up. So it's taking a lot of energy and time.
The United States has already invested over $300 million to develop anti-Ebola vaccines and treatments. Secretary Azar hopes his visit demonstrates America's commitment to the region.
If it helps reinforce the fact that we were in this before the first Ebola case and we're going to be there after the last Ebola case, and it's a part of a community effort and community engagement, well then I'm delighted if it had any impact.
That was Mil Arcega reporting, and he joins us with more on medical advancements that give hope to some Ebola patients that at one time had none. Mil, it's just extraordinary watching you report from DRC. Is that Ebola is no longer a death sentence.
Yes. That was the biggest takeaway from that. I'm happy to be here to talk to you about that because that was the big surprise for me as well. I came to Africa very first time in the continent. I didn't really know what to accept. What I found out was all I knew about Ebola was what I'd seen in films and what I'd read in books. What I found was that there's actually a lot of hope. There's 2 new drugs that they've introduced here following clinical trials earlier this year. And it turns out that they are so effective that they reduce mortality rates, at least in those people who receive it early enough, to about 3%.
Is it a drug once you get it, or is it a vaccine?
No, it's actually a drug. It's
once
a treatment.
You get Ebola.
That's right. It was developed from the blood of a survivor of the West Africa outbreak. They took him to the United States. They took parts of his antibodies and proteins from his blood. They developed 2 new drugs out of it. And what you have right now is probably the most effective treatment right now for the Ebola virus, at least a deadly form of it.
You know, when I watched your report, and I realized that there's some self-interest because a virus like Ebola could spread globally. Yes. But when I hear that the United States taxpayers have spent $300 million to help eradicate Ebola, and I see all the Americans on the ground, it does make me proud. That so far away, American taxpayers and Americans are doing what they can to help.
There has been some unfair criticism that the United States is not doing enough. But what I learned was actually the United States is probably taking the lead role in this far more than any other country in the world. And I think that was heartwarming for me as an American to see that our country is actually doing something about it.
Well, 5 years earlier, so I was in Liberia post-Ebola. All the with Samaritan's Purse was there and Doctors Without Borders fighting Ebola in Liberia, and I thought it was over. But apparently it's not.
Apparently it's not. The problem with Ebola is there's many isolated villages here, and people in these villages come in close contact with animals. Some of them may be infected. They don't know that. They eat some of these animals. Some of them are pets. And that close contact with wildlife, with nature, exposes some of these villages to the Ebola virus. And once one person is infected, it's only a matter of time before the rest of the village is infected. And then how do you stop it? How do you contain it?
What struck you about the treatment centers when you went there? I mean, that's the real eye-opener.
What struck me about the treatment centers was just how many Congolese, how many local health workers were actually working there. We're not just seeing folks from overseas or Doctors Without Borders treating these patients. We are actually seeing locally trained Congolese, trained by the CDC, trained by the WHO, actually administering some of this treatment. What I found scary about it were all the masks.
Yeah, we're all
in the outfits.
Oh, no,
right?
which we've seen. You spoke to the Cabinet Secretary Azar, the U.S. Cabinet Secretary, after he spoke with the President of the DRC.
Yeah.
What did he tell you?
Well, it was fascinating, first of all, to talk to the Secretary because I was impressed by his knowledge of the situation on the ground. I did not expect him to know about the treatments and about the history of what had gone on there. So that struck me. But he had meetings with all of the leaders from Africa, from DRC, Rwanda, and Uganda, to talk to them about the reasons why this is a global problem. Yes, we did speak with him outside right after his meeting with Felix Tshisekedi, the president of DRC.
And this is what he said to you.
Here's what he said.
We have a working relationship between the United States and President Tshisekedi, which is very productive. He has devoted himself to the health of the people of the DRC. He has personally traveled to the east to make clear not only the need to solve the Ebola situation, but rather also to improve the health of people in the eastern DRC, and we're partnered together on that. We discussed ways in which the response can keep improving. We also discussed ways in which the United States and the international community can help more broadly with building trust in the community in the eastern DRC. We need to ensure that faith leaders, community leaders, NGOs, and other healthcare providers trust. They trust the response, that it's not just about Ebola. It's about healthcare and lifting up communities there, because there often can be suspicion. This is a part of the world. This is a people that have suffered tremendously over many decades, and we need to build trust in these communities. That's a fundamental part of the Ebola response, but also generally of healthcare. So the United States has been the single largest donor and contributor of Ebola response in the world. The majority of response for the Ebola outbreak in the DRC has come from the United States. over $150 million of development and humanitarian aid, as well as $238 million of assistance from the United States to help develop vaccine, therapeutics, as well as the Centers for Disease Control and Prevention, response and technical assistance here in the DRC.
The United States is injecting hundreds of millions of dollars into the DRC to combat this problem. What does the United States get out of this?
First, we help public health in the world. People do not always recognize how much the United States contributes. We're the largest contributor to the World Health Organization. We support multilateral organizations. We support public health care. Through PEPFAR, the United States has helped develop the public health infrastructure here in Africa, here in the DRC. You know, when we had the outbreak in the Equator province of the DRC last April, it was the DRC that identified the outbreak. It was the DRC that did the testing. It was the DRC that did the gene typing of it. That was because of the PEPFAR and global health security agenda support and cooperation between the United States and the DRC that helped build up the capabilities here. One of the topics that we spoke with the president about was continued efforts. How do we help create a local CDC here in the DRC? How do we train more domestic capability and capacity? Because we want the government ministries here in the DRC to be able to deal with any of these health crises themselves eventually, but for now we want to support to make that happen and support that. And of course we have a deep friendship with President Tshisekedi, and we have as we've called it, a privileged partnership between the United States and the DRC, and this is also part of reinforcing that deep commitment. And I just want to say I'm very excited to now have Minister Longato as my colleague and peer, and to be able to have a partnership where we will work very, very closely together on Ebola, on healthcare, and as partners in the World Health community.
So do you feel like you've achieved what you set out to achieve while you were here?
Absolutely. We reinforce the commitment, we reinforce our connections, the transparency of our interactions, and we're able to have frank discussions about how we can improve the response, because it hasn't been solved yet, and so we need to always be working to improve, to learn, to get better, because it's a very unique outbreak in, frankly, a unique and challenged part of the world.
And Greta, the challenges are many in that part of the world, from the infrastructure, sewage infrastructure, road infrastructure, to their isolation, and to some of the cultural mistrust, which I think you'll hear about a little bit later in the program.
Mil, thank you. That's Mil Arcega, our producer for Plugged In. So what is Ebola? The virus got its name from the Ebola River in the northern part of the Congo. That's where the first known cases were identified. As for its origins, very little is known, but medical experts believe the Ebola virus originated in animals and spread by contact with humans. Since the discovery of the Ebola virus, there have been about a dozen outbreaks and nearly 13,000 deaths. The threat of cross-border transmission of Ebola prompted the World Health Organization in July to declare the outbreak a public health emergency. Following that declaration came support from the Centers for Disease Control and Prevention in the United States. The major areas of concern at the moment are the North Kivu and Ituri provinces in the Democratic Republic of Congo. But there have also been confirmed Ebola infections in South Kivu, as well as in Goma, which sits along the border with Rwanda. As of the end of September, there are no reports of Ebola infections in Rwanda. But to the north, a 9-year-old Congolese girl died from the virus in Uganda. The girl became sick in the DRC and crossed into Uganda with her mother to seek medical treatment. Efforts to contain the spread of Ebola have been hampered by pockets of violence in various provinces. The World Health Organization says the risk levels in and around the DRC remain high, but the likelihood of Ebola spreading on a global scale is low. Medical officials are calling for a more coordinated approach from non-governmental organizations and United Nations partners to combat and contain the spread of the virus. As we mentioned, 2 new drugs are bringing new hope in the battle to eradicate Ebola. And we spoke with one of the specialists, one of the scientists who played a key role in the development of new drugs and new vaccines that have dramatically reduced mortality rates for Ebola. Dr. Anthony Fauci is the director of the National Institute for Allergy and Infectious Disease, and he spoke with Plugged In's Mil Arcega about his role in the development of new treatments for HIV/AIDS and the parallels with his current research on Ebola virus, both of which viruses used to be death sentences.
We started off with each of them without any interventions at all. And that's sort of the historical comparability between them. When I first started getting involved with HIV, it was in the summer of 1981. The disease didn't have a name, we didn't know the etiology, and we certainly didn't have any treatments. And over a period of time, from something that was essentially a death sentence, I mean, if you looked at the mortality of HIV, until we developed the first drug in 1986-87, until we developed the triple combination in 1996, until the present day today, it's completely transformed the lives of HIV-infected individuals. Ebola, although it's a much different disease, it had the same degree of challenge because although we identified the virus right away, we knew what it was, the mortality was extremely high, anywhere from 60, 70, 80, and even more percent, depending upon the availability of health care. So what has happened over the last few years has been the development of two classes of interventions. One, a vaccine, which was shown in the West Africa outbreak to be effective in preventing, particularly among the contacts and the contacts of the contacts of index cases of Ebola. But the thing that really is quite exciting is most recently, just this past August, in a randomized controlled trial of 4 separate therapeutics to treat people who were infected with Ebola, it became clear that 2 of those treatments were actually significantly better than the control as well as another drug against which it was tested. So being here now in Africa, particularly our visit to the Democratic Republic of the Congo, where the clinical trial actually took place in the eastern part of that country, we were able to see the kinds of results that sort of harken back to the days of HIV, where you had something that was essentially a dreadful percentage of mortality, to actually see people who were treated, anywhere from infant babies whose mothers were treated before birth, to young children, to adults, who now have essentially recovered, as a result of good medical care, as well as, importantly, now a therapeutic, 2 therapeutics that work. Yes, it depends on semantics. I tend not to use the word cure. I said that we now have interventions that can dramatically reduce the mortality of the disease. When you say a cure, it's almost as if everybody who gets it is now going to be okay. There are still going to be people who come in so advanced that no drug is going to help them. But clearly, if you get one or the other of these 2 drugs, you dramatically diminish the mortality of Ebola.
So the key here is that the sooner you find out, you diagnose.
Exactly. One of the things we learned from the study, that the earlier you get into treatment, both general medical care and availability of these products, the much better off you are. Well, it is really a very important symbol to have the Secretary of HHS, Secretary Alex Azar, the Director of the CDC, myself as the Director of the Infectious Disease Institute, Tim Zima from USAID, to have those individuals representing the highest level, the medical aspect of the United States federal government, is a clear signal to these countries, but to all of Southern Africa, that the United States is committed to stepping in when we're needed.
Did you learn anything new during your visit here?
It isn't that I learned anything new, but I was clearly impressed at the capabilities of the Congolese who are administering the care here, as well as the preparedness of the Rwandans and the Ugandans in case cases spill over the border. So I was impressed all around with the capability of these Southern African and Central African and East African countries.
The challenges of treating Ebola in that part of the world are well known to our next guest. Dr. Malunga Miatudila was among the first to uncover and identify the Ebola virus. He began studying the effects of the virus in 1976 after a colleague brought it to his attention. He once served as advisor to the Minister of Health in Zaire, which is now the Democratic Republic of Congo, and he later served as a senior public health specialist for the World Bank. Thank you for joining us, Doctor.
Thank you for having me.
Doctor, this is great news. 2 therapeutics or drugs to once you get Ebola that may save your life or likely to save your life. But is there any challenge to getting it to the patients?
That's a problem. That's a big problem that we have now, is that we have not been able to develop trust between the health providers, health system, and the population.
Is that because there are people from who aren't from DRC who are part of the chain of supply of medical care? I mean, why is there no lack of trust? If were there more Congolese taking care of it, would that make a difference? Because apparently there are many in these treatment centers.
Based on our experience that we had in Yambuku in 1976, we have learned that for you to be able to control the epidemic of Ebola, you have to rely on local people. Not only people coming from outside the country, but even people coming from Kinshasa. You don't have trust with the local people. So the first thing to do is to go through local people.
What's the impediment to doing that? Why not go to local people? It seems like a simple solution to build trust.
Yeah, it looks simple, but for most physicians, we are experts. We are medical experts. We think that once we have the bullet, we can shoot the disease. But it's more complicated when you are dealing with a disease in human population. The virus is harbored by a person. So you have to go through that person first to get to the virus. And you have to build the trust for that person to accept what we are providing.
I was in Liberia right after the Ebola crisis, and one of the troubles that they had there was sort of a cultural thing, is that people, when someone died from Ebola, for instance, they wanted to bathe the body and touch the body, which naturally increased the risk of spreading. This is before these 2 therapeutics arrived on the scene. Are there cultural problems with the trust in DRC?
No, DRC is not different from other countries, even the United States, in terms of building trust. It's very simple. I think that what you have to do when you're coming to a foreign place, when people don't know you, the simple thing is to identify the leaders, the people whom the community trusts, and then you go and you walk through that person or persons to get to the population. This is what we did in 1976 in Yambuku. We're coming from outside. Some of our friends came from United States. Some of us came from Kinshasa, but we were in Yambuku in a very isolated area in the northern Equator. So what we did, we identified people who have been living there for more than 40 years, and these people were Belgian nuns. So we worked through them to communicate with the locals, and this is how we were able to control Ebola in less than 4 weeks. So that's the trick.
Going back to 1976, when it was first identified, you were first involved in the identification of Ebola. What was it that your colleagues said to you that got you into this?
76 was a very dangerous moment because we didn't know anything about the disease. Nothing. The only thing we knew that the disease was killing a lot of people.
And you didn't know where it was coming from?
And we didn't know where it was coming from. The bugs, what is it, a virus or a bacteria or something else? We didn't know. So we went there knowing nothing.
So what did you do?
So when you go there, but there we have some tricks because we are coming from the public health sector. We look at the symptoms and how the disease was spreading, and we discover first that only nurses, even among the nuns who were living together, only nurses died. Those nuns were not involved in the medical care, survived. So we knew that it was something that we were getting by nursing, by caring for patients. So that's the first thing. So, and if we since we didn't know how it was being spread, we said we are going to isolate communities. So no touching, no touching patients, and that was the end of the disease when people were isolated. And then we told them not to touch people. It was very hard because that went against the cultural norms. But by using nuns, local nuns, although they were Belgians and they were white, but they could better communicate with the population.
I look at I see HHS Secretary Azar going there, and I see being interviewed by Armil Arcega, and I see how informed he is. How is that received? Do you think in the DRC when they see a secretary of a cabinet from the United States coming there and taking a look and exploring and seeing what he can do?
Oh, I think that's a very, very good move, because now people can see that people outside North Kivu, they do care. Because now we have a very big problem of trust. Local people, they don't trust people outside their small area. They don't even trust the regional capital. Now what about Kinshasa, and what about the outside world? So when they see somebody coming from Washington, from a high official coming from Washington, they say, oh, maybe now they can listen to what.
We've come a long way since 1976 with Ebola, haven't we?
But from 1976 till yesterday, I would say, we have had nine epidemics. And by using the same techniques of relying on local people, we have been able to control most of those, all of them, in less than 5 weeks.
And it's just even amazing, since even the outbreak in Liberia, when we didn't have the two therapeutics that are now seem to be the two medicines. It's pretty amazing. But anyway, Doctor, thank you very much for joining us. And before we go, an update on the situation in Hong Kong, where some police are now using live ammunition on protesters. During the protest on October 1st, one teenager was shot in the chest and critically wounded. October 1st is the same day China celebrated the 70th anniversary of communist rule. Hong Kong police say the officer was being attacked by, in their words, rioters, and that the police officer fired the shot, quote, in order to save himself and his colleagues. Until now, police have used tear gas, rubber bullets, and beanbag rounds on protesters. Next week, Plugged In will be on the ground in Hong Kong, and so you will see and hear from the people involved and better understand what is at stake there. That's all the time we have for today. Stay plugged in by liking us on Facebook at Voice of America. And you can also like my Facebook page, and you can also follow me on Twitter at Greta. Thank you for being plugged in. See you next week.